Hello, everyone. I'm Dr. Zhang. I'm a colorectal surgeon. I'm very happy to be here today and talk about colon cancer and the rectal cancer, and also talk about colorectal surgery. All right. This is our topic today. Talk about colorectal cancer. Talk about prevention, screening, and treatment. All right. So first, let me talk about colorectal surgery. So colorectal surgery is three-part in general. Number one, called colorectal cancer. Number two, called IBD, which is inflammatory bowel disease, including ulcerative colitis and Crohn's disease. And also, we talk about benign colorectal disorders. So those we are going to focus on colorectal cancer today. And I'm going to talk a little bit about IBD, all right? Okay, colorectal cancer. The most common colorectal cancer called sporadic colon and rectal cancer. And also we have some colon cancer syndrome, such as FAP, and you may hear about Lynch syndrome, also called HNPCC. Like we mentioned before, ulcerative colitis or Crohn's disease sometimes give you a higher risk for colon cancer. And another one called colon cancer X, which is with unknown genetic change. So we are going to talk about today, number one, it's called epidemiology. And we're going to talk about causes of colorectal cancer, genetics, how to screen colorectal cancer, treatment, and hopefully I have some time to talk about new technology in terms of colorectal surgery. So first, we talk about colorectal cancer epidemiology. So as you know, approximately 1 million cases worldwide annually, which is second most common cancer if you put male and females together. In the United States, approximately 150,000 new cases, we call the colon and rectal cancer, also called large bowel cancers. 100,000 new cases of colon cancer, approximately 50,000 new rectal cancer. Sometimes they are lethal. About 50,000 deaths every year. So in general, for everyone, we have 4% lifetime risk. So look at this picture. This is new data from 2021, this year. So basically you look at upper panel, which is new cases. You can look at both male and females. Colon and rectal cancer is number 3. The same, like a lower part in the estimate death is about number 3. So, but if you put male and female together, they will be number 2. The cancer death, you say male and female, pretty high, still pretty high. The blue curve is cancer, and it's still going up, even though nowadays it's flat a little bit, but it's still high. So look at colorectal cancer incidence by race. So the older population here, you can see that is pretty high. All races, the cancer incidence pretty high. That's so important. That's why we talk about how to prevent cancer, how to identify them early. So like we talked about before, underlying causes, the number one called sporadic cancer. It's more than 50% called sporadic cancer. In general, they are we call the average risk. You and me with no family history, but suddenly they have cancer. Number 2 is the population. They have family history of colon or rectal cancer. You can see the syndrome. One called FAP, about 1%. HNPCC, about 5%. We talk about colon cancer X, which is a syndrome. We don't know what's going on. We don't know the genetic mutation. So that's the underlying causes of colorectal cancer. So I summarize 10 risk factors to give you colon or rectal cancer. We talk to our patient all the time. The patient always asks me, I don't have family history. I don't have personal history. Why I have colon cancer or rectal cancer? Give you a quick story. Yesterday afternoon, I saw a young patient, very young, 37-year-old young lady, otherwise healthy, exercise, no family history, suddenly present with rectal bleeding. And after colonoscopy, we identify a large cancer in the rectal sigmoid junction. So those happen almost every week. So why is it happening? So we don't know. So that's why we talk about these risk factors. There are no single cause give you cancer, but look at them together. The multiple factors. Number one is age. We know that age is number one risk factor. Average age for colon or rectal cancer is 64. About 90% of colorectal cancer older than age 50. All right, so you can see. But however, for younger patients, that's important too. We know that the younger population, the colon cancer rate going up. The other population actually going down. And number two is family history. First degree relative, what that means parents, siblings, and children. One first degree relative with colon cancer, your cancer risk going up, 2.3-fold increase. If you have two first degree relatives, the cancer risk going up 3 times. If you have 3 first degree relatives, that's even 10 times. That now we talk about probably need genetic testing. Personal history of polyps. After your first colonoscopy, let's say we identify a polyp or 1 or 2, or depending on number and size, the risk, cancer risk different. Smaller, less polyp is a lower risk. If the polyp bigger or more, you have higher risk for cancer or polyps down the road. IBD, we talk about, include ulcerative colitis and Crohn's disease. After about 8 to 10 years of IBD, the cancer risk going up. You can see the number here, right? After 8 to 10 years, 2% cancer risk. And after 20 years, 8%. So recently, we have several patients with ulcerative colitis present to the hospital or my office. 2 of them developed cancer. So we're going to talk about how we treat them. We treat them is a little bit different from we call sporadic colon cancer. Diabetes. Diabetes gives you a higher risk for colorectal cancer. There's a pathway because increased cell proliferation. Obesity. Obesity, we talk about what that means, obesity, and BMI, right? BMI greater than 30 is obese. So about 1/3 of population, they are obese. So they have higher risk, 2 to 4-fold increase in terms of colon and rectal cancer. Alcohol, in general, alcohol doesn't help your colon and rectal cancer. It gives you a higher risk. Smoking almost causes every single cancer we know. The colon cancer is the same. Increase 1 to 2-fold if you smoke more than 20 a day. Stop smoking. That's why I tell my patient, almost every patient, before surgery or now is the time to stop smoking. Number one, not good for colon cancer. Number 2 is not good for wound healing and the post-op complications. Exercise. Look at that. We know that exercise decreases your cancer risk, especially colon and rectal cancer risk. Look at this facility. You don't need to exercise. You can go there. And diet. Western diet, what that means low fiber, high fat, a lot of refined food. That doesn't help. We make joke all the time. big stool, small colon and rectal cancer. And the small stool means you're constipated, you don't go to the bathroom every day, you have a higher risk for colon cancer. All right, so hopefully we are doing okay. So we are moving down to the genetics. All right, this is a very simple pictures. Hopefully, whoever watching this, memorize this, please. All right. So why I show this? Because I can tell you it's very complicated, and which means multiple gene involved and multiple steps, right? So basically, is cell growth and proliferation and the cell dies. Let me show you some pictures, simple. This slide from my mentor, Dr. Church from Cleveland Clinic. The first picture basically showed oncogene and tumor suppressor gene. What that means is one is stop growing, one is cause cell proliferation. So the second one is we call it apoptosis, which is cell death. When the body or gene damage too bad, and the cell decide to cause apoptosis, cell death. The third one is DNA repair, and the repair gene is important for you too. So again, oncogene and the tumor suppressor genes. One's a good guy, one's a bad guy. The oncogene we talk about is bad, but when they become mutated. Mutation causes cell proliferation, then stop growing. On the other hand, tumor suppressors, which is good guys, such as you may hear about the P53 or APC gene, they are good. When they have mutation, or we call the loss of function, and cancer comes. Again, this we call it oncogenesis. As we know, almost every single colon cancer or rectal cancer, they start from a polyp. From polyp to cancer is multiple steps and multiple genetic changes. Average take about 5 to 10 years. Like a patient asks me all the time, I have a big cancer. I need surgery quickly, and the truth is, you have this cancer when the cancer presents with symptom, bleeding, obstruction, or perforation. The cancer stay in your body already 5 to 10 years, not like yesterday or last month. So that's why the screening, early diagnosis is so important, right? That's the pathways. The cancer goes through different pathways. However, when they eventually the cancer develops, the pathway is why important, because now we do genetic testing on the specimen. Based on the genetic change, we treat them differently. For example, the first one called suppressor pathway, the second one called the mutator pathway, and the methylator pathway. The different gene involved, different mutation, and that's why we do genetic testing, and hopefully can. That's why we talk about every single patient. We treat them different, depends on their presentation, depends on their gene mutation. So this is the first pathway called the suppressor pathways. That's the most common one. More than 50% of colon cancer, rectal cancer, from this pathway. You can see that multiple gene mutation. Number one called APC, and gradually from normal, gradually become cancer, and multiple gene involved, and mutation happen. This pathway involves most of the sporadic cancer, but also in the FAP population. Another pathway, this one involves called the DNA repair genes. So look at those guys. They are repair your gene damage on daily basis. When they become mutation, we basically lost this function. They can repair the gene damage, and then the cancer develop. That's why when they have those repair gene mutation, we call it microsatellite unstable. So those population or cancer, sometimes we treat them differently in terms of chemotherapy, such as after surgery, the treatment different. So in general, as you can see, the colon and rectal cancer are multiple genes involved and multiple steps, and different in clinical response and outcome. This difference need to be recognized. That's why we treat them differently. We discuss patient care, every single patient differently, both clinically and for research. Okay, so let's move to screening. We talk about screening is important, right? So we do colonoscopy almost every day. We talk about what should we do in terms of what's the best for in terms of screening. So we know that this is called the HNPCC staging system. When we talk about colon cancer or rectal, any cancer, the language of cancer is staging. This is 7th edition. Now we have 8th edition now. So we know that cancer, early cancer, almost always curable. You can see the figure, right? Stage 1, the upper one, is above 90% cure rate. Stage 2 and stage 3, 4, the later stage, the less likelihood to survive, right? So that early diagnosis screening is important. Look at this colon. So I talk to my patient almost every day. The beginning of the colon called the cecum, and then going up called ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. The cancer can happen anywhere in the colon and rectum, but if you take a closer look, it's about 62% on the left side. So who needs screening? So almost everyone needs screening. So we have 3 groups of population. One called average risk, the most population. They have no symptom, no family history, no personal history, no IBD. IBD means, hopefully you remember, called ulcerative colitis or Crohn's disease. They are healthy young people. They called average risk. So, and the second group called increased risk, with personal or family history of colon and rectal cancer, and the high risk population called FAP or HNPCC, sometime after 10 years of IBD. Screening options. We know that the gold standard test is colonoscopy. If you can do colonoscopy, just do colonoscopy. The other options are available, but none of them as good as colonoscopy. All right, I'm not going to spend too much time on the other options. But recently, you probably hear about Cologuard. Cologuard, more and more patients come to my office with Cologuard, positive Cologuard. What that means? That means Cologuard is a stool DNA test. So when you have positive Cologuard, next step is colonoscopy. So we highly recommend if you're okay, you're healthy, you do your colonoscopy. So you can see that another technology called the CT colonography on the left side. Now we talk about how we do this. In terms of stage, what time we do colonoscopy? We know that in the past, the colonoscopy start from age 50. Last couple of years, changing. So more and more organization switched from 50 to 45 now. You do your first screening colonoscopy at age 45. If your colonoscopy normal, so you will need another one in 10 years. Some other alternative tests I don't really recommend, but it's available here. Increased risk, what that means? That means increased means when you have family history. When you have family history of colon cancer, the first screening colonoscopy starts from age 40 or 10 years younger than the youngest colon cancer in the family. All right. After that, because of family history of colon cancer, we change it to every 5 years, not 10 years afterwards. High risk screening. High risk means you have some gene mutation, genetic change. The first one called FAP, that is APC mutation. That if you have this gene mutation, you have 100% risk develop cancer. So recommendation is the first colonoscopy or flexible sigmoidoscopy at age 10 to 12 years old. So, and the genetic counseling, genetic testing. If testing positive, you need surgery, right? Before cancer develops. We're going to talk about how we do this kind of surgery. Number 2 is called HNPCC. It's another gene mutation, DNA repair gene mutation. When you have those DNA repair gene mutation, colonoscopy every 1 to 2 years, start from age 20, 25, right? Or 10 years younger than the youngest cancer in the family. And also we need genetic testing. All right. Another colonoscopy called surveillance colonoscopy. We talk about screening, we talk about screening colonoscopy, and talk about surveillance colonoscopy. What that means, surveillance? Surveillance means, let's say some patient develop cancer. We do surgery. After the treatment done, you need a colonoscopy within a year. Or you had polyp before. And depending on the size and numbers, and the next colonoscopy either 3 or 5 years. Or the patient has ulcerative colitis or Crohn's colitis. After 8 or 10 years, you need a colonoscopy every 1 to 2 years with multiple biopsies. So now we move to colon and rectal cancer treatment. Now our favorite topic, talk about surgery or other treatments. When we see patient come to the office or hospital, the number one we have to think about, can we cure the patient? Is a curative operation possible? Right? And we need to do staging, like we talk about. The cancer, the language of cancer staging. The staging means the patient, the cancer localized in one area or involve adjacent organ. Do we need neoadjuvant therapy? What that means? That means any treatment before the surgery. Or what kind of treatment patient needs? What time we do the surgery? Can we just closely watch patient without surgery, such as like a rectal cancer now changing, the manager of rectal cancer changing. Some patients we can watch them closely. In general, we see patient in the office, we schedule surgery, like colon cancer surgery, called elective surgery. But sometimes we see them present to the emergency room when they have obstruction, bleeding, or perforation. When we do emergency surgery, sometimes involves stoma. For elective surgery, most of the time we don't need that. And also, when we talk about cancer, we talk about staging. When you have lymph node involved, in general, when you have lymph node involved, you may need a chemotherapy. Or stage 4 cancer, you may need a chemotherapy. Now we talk about operations. So I show you the colon picture before, right? Really depends on the location of the cancer. If the cancer located on the right side, like let's say in the cecum or ascending colon, we do a procedure called a right hemicolectomy. Remove the right side colon and reconnect your small bowel to your transverse colon. Or the cancer located in the transverse colon, we can do remove that part of the colon, or do a called extended right hemicolectomy, remove that part of the colon. When we do this surgery, not only remove the colon, but also remove we call them mesocolon or mesentery, all the lymphatic, vascular drainage, everything come out together. We call the total mesocolon resection. Remove the cancer and the lymph node, everything together. When you see the cancer on the left side, we do called the left hemicolectomy, remove the left side and rejoin them together. However, like we talk about, when patient present to the emergency room with blockage, obstruction, look at the proximal colon is big, right? Bigger than normal. So it's not safe. It's not safe to join them together. When you join them together, they may leak. We try to prevent complication. Usually the patient come with we call it a colostomy bag. It's a temporary colostomy bag most of the time, and we want patient get better quickly and may need chemo. And after everything done, we can rejoin the bowel together. This last 5 years or so, the rectal cancer treatment changing big time. So you can look at this picture. We have MDT team for rectal cancer, but not only rectal cancer, all the cancer, colon cancer same. But rectal cancer is critical. You can see that 5 components. The surgeon, colorectal surgeon in the center. We also need radiology, medical oncology, radiation oncology, and pathology. We work like one team. We talk to each other all the time. We have conference twice a month, talk about every single cancer patient. So give you a little bit story. In 2011, a group of colorectal surgeons start this program, and this one slowly become national rectal cancer program. So the 4 key principles in terms of rectal cancer care is: number 1, surgery is critical. It's a key called the total mesorectal excision, TME. And also we talk about standard pathology report. We need pre-op MRI. We need to discuss MDT discussion every single patient before, after treatment. So this is the rectal cancer surgery. The cancer in the rectum really depends on where in the rectum, upper rectum, mid rectum, or lower rectum. We treat them may different. When patient ready, we do surgery, take the cancer out after neoadjuvant chemoradiation or chemotherapy. This is what we do years ago, called open surgery. Open surgery means you open from up and down, big cut, and you take the colon out and the rectum out. You can see everything in your hand. So this is our result. Look at the specimen removed, and after you remove this, we usually give to pathologists. We open the specimen, make sure the margin everything clear, and we do a pathology evaluation in terms of final staging. We're going to talk about new technology later. Let me give you a story. This is one of my patients about 5-6 years ago. A young lady, 37-year-old young lady with long history of UC, ulcerative colitis. We talk about after 8 to 10 years, you do surveillance colonoscopy. On the surveillance colonoscopy, we identify a small colon cancer on the descending colon. The question is, what's next step? What should we do next? So we treat ulcerative colitis or FAP or HNPCC is different from sporadic cancer. Just segmental resection, not enough. In the history, when you see a cancer on the UC patient, the whole colon and the rectum need to come out. So in the past, the procedure called total proctocolectomy with and ileostomy. What that means you remove the whole colon and the rectum, and you leave with a permanent bag called the ileostomy. That's in the history. For that young patient, we didn't do that. We did called the J-pouch surgery. We can remove the colon and the rectum and rejoin them with a J-pouch. you can live a normal life, but no bag outside. So that's what we do, like open surgery, how we create the J pouch. After you create the J pouch, you reconnect the J pouch to the anal canal. This is our procedure called IPA, also called J pouch surgery. So after everything done, you'll have normal continuity and a normal life. Nicole is one of my patients. She wants to share her story with us. She has no cancer, but she had ulcerative colitis years ago. We did that J pouch surgery on her and, at that time, and she's happy. So for her, we did early, like more than 5 years ago, we did a robotic J pouch surgery. So what that means, robotic means, we know that in the history we do open surgery and gradually laparoscopic surgery. Now there's more and more new technology, robotic surgery. So basically nowadays we do surgery like this, more like the left side is a surgeon. We sit on the console. It's a robotic console, just a bigger video game, just play the game in the console. The right side is on the table you can see the patient there, and we dock in the robot arm in the abdomen, and we can do surgery, totally non-touch now. So you can see the difference, right? Open surgery on the left side, up and down, big cut. And the right side is robotic surgery. You have small incisions. What that means you have less pain, less discomfort, go back to work, go back home sooner. This is my robotic room. You can see that on the right side is a robotic console. There's my toy operating here. It's my team start setting up the room and setting up the robotic arm, and a lot of people involved, sometimes more people than this. And when we're ready, the patient will bring patient in and position the patient and do surgery. It's another story, another young lady. She has no colon cancer. She has another disease called SMA syndrome. So what we did is we did the robotic surgery, and she's very happy. I just saw her not long ago. She's good. I want to show you some video. Okay, this is one of my rectal cancer surgery. I did robotically. So you can see that very clear the operative field. So no bleeding. You do everything precisely. And you can see that we are, dissecting the big vessel. That the big vessel we don't want injury cause bleeding. That by using the robotic tool, and we can do everything just like this is 3D vision, just like as good as open surgery. So we can move forward quickly. You can see that we can we identify everything. Now it's ready to transect the big vessel. So now after transected, and we can identify everything and moving down to the pelvis and take the rectal cancer out. You can see that very clear picture. And if you stay in the plane, there's really not a whole lot of bleeding. When you're ready, and you can just go ahead transect the distal rectum. So we do a lot of like robotic surgery. Again, like say, I told you the story yesterday. I saw a young lady, 37-year-old lady, after evaluation. Her cancer in the upper rectum, all the way to the rectal sigmoid junction. So we look at all the staging image and all the record. So she gonna have robotic surgery next Friday. So she will do well. And more than that, recently we are doing we call the NAPRC rectal cancer program. in Waterbury. Hopefully, we can get ready by this year. Another new technology I want to share with you, in the future, we may start doing that, called transanal single port surgery. Okay, so again, we talk about every year in March, we talk about colorectal cancer prevention, screening, treatment. So if every year we after talk, we can have discussion with my patient or other people in the room. But this year a little bit different. So if you have any questions, you can call me in my office. We can have a conversation, or you can want to see me in my office. I'm very happy to discuss any problem you have. All right. Thank you very much. Thanks for watching. Hopefully you can remember everything I said.